Dr. Sharma is up, personalizing care in early-stage triple-negative breast cancer.
Good morning, everyone, and thank you for being here at such early hour on a Saturday morning. So I'm going to talk about three separate areas: perioperative immune checkpoint inhibition, which includes both neoadjuvant and adjuvant components, the role of adjuvant PARP inhibitors, and newer agents, specifically ADC, on the horizon in treatment of early-stage triple-negative breast cancer. So let's just start with chemotherapy backbone. This is a summary of all phase 3 carboplatin trials that evaluated addition of carboplatin to ACT backbone, either in adjuvant setting or a combined adjuvant and neoadjuvant setting. And the summary is 4 of these 5 trials show improvement in long-term outcomes, and 3 with improvement in overall survival. And this kind of gives us a backbone of how KEYNOTE-522 was designed. You all are very familiar with KEYNOTE-522 trial, which showed that addition of neoadjuvant and adjuvant pembrolizumab to chemotherapy improves event-free survival and overall survival. The chemotherapy backbone in KEYNOTE-522 included carboplatin to ensure that addition of pembrolizumab was additive to the most efficacious neoadjuvant chemotherapy regimen. NACP B59 or GEPAR-DUS was presented at San Antonio in 2024 and designed very similar to KEYNOTE-522, but evaluated PD-L1 checkpoint inhibitor atezolizumab. This was added to ACT backbone. So the key differences between this and KEYNOTE-522 is this trial allowed AC scheduled to be both dose dense and Q3 weeks. In KEYNOTE-522, it was only every 3 weeks. And this trial allowed the use of adjuvant capecitabine and adjuvant olaparib in patients with residual disease, whereas KEYNOTE-522 did not allow that. And this trial only used AUC of 5 every 3 weeks for its carboplatin schedule and did not include the weekly dosing of carboplatin. The primary endpoint for this trial was EFS. At the primary endpoint analysis at the 4-year EFS mark, there was a numeric 3.3% improvement in the atezolizumab, but this difference was not statistically significant. When we look at subgroups from this trial, we see the patients with node-positive disease benefited more, and this difference was statistically significant with p-value for interaction at 0.039. And we see some trend for patients who had high TILs, specifically those that had more than 30% TILs. They tended to benefit also more from the addition of atezolizumab. So let's look at these 2 trials side by side. In KEYNOTE-522, at the 3-year mark, the improvement in EFS was 7.7% versus 3.9% in B59. We can see that the patients on the control arm in KEYNOTE-522 do a little bit worse than what they're doing in B59, with almost 84% 3-year EFS versus 77% 3-year EFS in KEYNOTE-522. When we look at PCR by arm in B59, what we see is especially the patients who had residual disease in B59 are doing much better than what they did in KEYNOTE-522. B59 also enrolled a relatively lower risk patient population, and we do see a suggestion of benefit in those with node-positive disease in subgroup analysis, and 50% of patients with residual disease utilized capecitabine, perhaps explaining the better outcomes of patients with residual disease in this trial. What about adjuvant IO without a neoadjuvant component? Impassioned 030, Alexandria evaluated this question, again using atezolizumab. These are patients all that had surgery up front and were receiving ACT-based adjuvant chemotherapy with or without atezolizumab. This trial was actually halted early because of futility, as the atezolizumab arm was considered to be not performing very well, and you can see that very well with the 2 curves that are overlapping with each other. This suggests that the timing of IO matters in treatment of early-stage triple-negative breast cancer. It's more effective when given before surgery as opposed to after surgery. What this trial didn't address is the role of IO in residual disease after preoperative chemotherapy. ABRAVE looked at this question in a subgroup. This trial enrolled patients who either had surgery up front and high-risk disease or had chemotherapy up front and had residual disease, and had co-primary endpoints of DFS in the entire trial population and those that had received neoadjuvant chemotherapy and had residual disease. So if we focus on the Kaplan-Meier curve on the bottom, we see that there's a numeric 6.2% improvement in disease-free survival in patients that got the checkpoint inhibitor therapy versus that didn't after surgery, but this difference was not statistically significant. Again, we see the number of patients in this strata are small. This question is definitively being asked in SWOG 1418, which compared adjuvant pembrolizumab to observation in patients who had received neoadjuvant chemotherapy and had residual disease. This trial is over 1,000 patient big, has completed enrollment, and we're just waiting for maturity of survival data and reporting. So if we're using immunotherapy up front with chemotherapy, can we de-escalate the chemotherapy backbone for our patients? These are some results from NeoPAC trial, which was a single-arm trial of 6 cycles of carboplatin, docetaxel, and pembrolizumab without adjuvant pembrolizumab, showed a PCR rate of 58% and 3-year event-free survival of 86%. Immune enrichment, as assessed by several different markers, was noted in almost half of the patients that were on the trial and was associated with very high PCR rates exceeding 70%. NeoN trial also asked this question in relatively low-risk patients, stage 1 and 2 patients. This trial evaluated 4 cycles of platinum, taxane, and nivolumab, and had a lead-in phase of 2 weeks of nivolumab in one of the arms. The overall PCR rate was 53%. The lead-in did not lead to better PCR rates, and as has been observed in other trials, immune-enriched tumors showed a higher PCR rate, again reaching or exceeding 70%. EFS data is pending from this trial. So there are trials that are assessing chemotherapy de-escalation in early-stage triple-negative breast cancer. SCARLET or SWOG 2212 is a non-inferiority trial that is comparing the KEYNOTE 522 regimen to the NeoPAC regimen. This trial will enroll 2,400 patients and has reached halfway enrollment mark. TILs are being assessed prospectively as integral biomarkers. NeoTRACT is a smaller study that is looking at escalating or de-escalating the chemotherapy elements and the duration of chemoimmunotherapy based on baseline TILs and radiographic response. This trial has also completed accrual and should be reported at ASCO this year. What about the role of neoadjuvant TROP2-directed ADCs? ADC as monotherapy were assessed in 2 different trials. The NeoSTAR trial looked at 4 cycles of sacituzumab, leading to a PCR rate of 30%, and I-SPY 2.2 had an arm of Dato-DX alone, which showed a PCR rate of 35%. So these PCR rates are modest and don't compare very well to what we expect to see in this modern era. I-SPY 2.2 also had an arm of Dato plus Durva, so now combining a TROP2 ADC with a checkpoint inhibitor. In this arm, overall in patients with triple-negative breast cancer, the PCR rate was 44%, but if we look at those that had immune-positive subtype, the PCR rate there was 65%, and this particular subtype met the threshold to graduate to study further the combination of ADC plus IO. As we look at patients who have a PCR, which is one of the questions that we just looked at, what is the benefit of adjuvant immunotherapy after PCR? And we can see at the 5-year mark, patients with PCR are generally doing very well, and the difference between those that received pembro versus not is small. And again, we can't tell the contribution of the adjuvant versus the neoadjuvant part from KEYNOTE 522. So this very important question is being assessed in optimized PCR trial being led by Sarah Tilloni, that is enrolling patients who have had a PCR after neoadjuvant chemoimmunotherapy and randomizing between observation and pembrolizumab. Patients with PCR do very well. On the other hand, we know the patients that have residual disease have high risk of recurrence. So what can we do to improve outcomes for those patients? Olympia was a landmark trial that enrolled patients with germline BRCA102 mutation. The TNBC subgroup was either those that did not have a PCR after neoadjuvant chemotherapy or had surgery first and had stage 2 or stage 3 disease. And this trial showed that a year of olaparib compared to placebo improved both invasive disease-free survival and overall survival. So obviously a very important treatment that is available for our patients with germline BRCA1 or 2 mutation. Again, as we look at Keynote 522 and look at the residual disease curve, we see that 36% of patients are still having an event despite receiving neoadjuvant and adjuvant pembrolizumab. So we need better treatment options for these patients, and there are several trials that are assessing that. ASCENT-05 is looking at sacituzumab plus pembro versus standard of care. TROPION-Breast03 is looking at Dato-DXd either with durva, it also has an arm of Dato by itself versus standard of care. SASIA, which is completed enrollment a while back, enrolled patients with both hormone-positive and triple-negative breast cancer with residual disease and compared sacituzumab to treatment of physician's choice. And we also saw that this question is being assessed in the TroFuse trial with sac-TMT in combination with pembrolizumab versus treatment of physician's choice in patients with residual disease. So a lot to come in this area. TROPION-Breast03 has completed accrual, and ASCENT-05 is very close to completing accrual. So over the next year, we hope to hear results from these trials. What about moving ADC even up front in a neoadjuvant setting? So TROPION-Breast04 is comparing 8 cycles of Dato-DXd plus durva to Keynote 522 regimen and asking the question if ADC plus IO can replace 6 months of polychemotherapy plus IO in early stage TNBC. TroFuse-032 is evaluating another TROP2 ADC, sac-TMT, and here the sac-TMT is replacing the AC part of the Keynote 522 chemotherapy backbone and asking the question if ADC plus IO can replace the ADC part of the neoadjuvant therapy. Several efforts have been made to figure out if we can tell which patients preferentially benefit from immunotherapy. We know these drugs have side effects, and several markers have been evaluated. Most of them are just prognostic, but they don't help us identify patients who have preferential benefit from immunotherapy, with the exception of few that have shown some promise in retrospective analysis that are highlighted here in yellow, and further analysis in larger trials of these biomarkers is ongoing, so stay tuned. So in terms of early stage triple-negative breast cancer, the key takeaways and knowledge gaps, we know that addition of pembrolizumab to anthracycline taxane platinum-based neoadjuvant chemotherapy improves event-free survival and overall survival. The PCR improvement in Keynote 522 was actually not very robust, modest, but it's leading to much more long-term improvements. We do see encouraging efficacy with shorter duration of taxane platinum-based chemoimmunotherapy or ADC plus IO, specifically in immune-enriched tumors where we see very high PCR rates. To date, there are no clinically available patient selection biomarkers to identify who should take immunotherapy versus not, although this is an area of very active translational research. There are several areas of knowledge gaps. Do all patients need 4-drug polychemotherapy when immunotherapy is part of neoadjuvant systemic therapy? Can we de-escalate chemotherapy in trials like Scarlet, NeoTract, and some arms of I-SPY 2.2 are attempting to answer this question. What is the role of adjuvant checkpoint inhibition in setting of PCR? Optimized PCR studies asking this very important question, and in setting of residual disease. Do all patients need chemotherapy plus immunotherapy? Can we identify patients who would not need or are unlikely to benefit from chemotherapy? And improving outcomes for residual disease is an important area as those patients still have a high event rate.